Hi, good afternoon. So today we are going to talk about pulpectomy. So last class we spoke about pulpotomy, how pulpotomy is done, what are the procedures, what are the different types of pulpotomy, how can you classify pulpotomy. So now next we are going to the next level, that is pulpectomy. So what do you mean by pulpectomy? So pulpectomy is a procedure that should be termed as a partial pulpectomy, as it is not possible to remove the complete pulp tissue from the delicate network of canals. Pulpectomy means, as the name suggests, pulpectomy. Pulp, the entire pulp you are removing from the canal. Okay, so both in pulpectomy procedure you will be removing both the coronal as well as the radicular pulpal tissues. So coming to the objectives, why you are doing a pulpectomy? Okay, or what are the objectives of doing a pulpectomy? So uh, to gain access and to remove as much as dead and infected dentine from the teeth. So first you're gaining access to the pulp chamber and removing the entire as much as dead and infected dentine you are removing. Second is the maintaining the teeth free from infection. That is same as pulpotomy, what we have discussed earlier. Then biomechanically cleanse and obturate the root canals, promote physiological root resorption, and hold the space for the eruption of the permanent tooth. So these are the basic objectives of a pulpectomy, the need for doing a pulpectomy. Now coming to the general indications, a good, a good general health with no serious disease. Okay. Next is a cooperative child. So these are the general indications where you can give a pulpectomy procedure. Now clinically, if there is a presence of a draining fistula, you can see if there is a draining fistula present, it's difficult to do you cannot do any other pulpotomy procedure or pulp capping. The fistula clearly shows that the pulp is necrotic or the infection has gone into the pulp chamber. Next is, and for pulpotomy shows uncontrolled hemorrhage or dry pulp chamber. So this is what is called as an uncontrolled hemorrhage. Even though if you are keeping a moist cotton pellet for a longer time, okay, for more than 1 or 2 minutes, the pulp is not getting, the bleeding is not stopping. You are getting profuse bleeding from the canal, which shows that the radicular pulp is infected. Then when you are opening, you are thinking, okay, fine, we can do pulpotomy, and you're opening the tooth, but when you open, your entire pulpal chamber is dry, which means that it's a necrotic pulpal tissue is there. Then pulpous primary tooth with a sinus tract, then pulpous primary teeth without permanent successors. Okay. So these are the clinical features of where you can do a pulpectomy procedure. Now is the radiographic features. So radiographically, the radiolucency extending up to the pulp means radiographically, if in a radiograph you can see it's extending up to the pulp. Okay. Then early signs of internal resorption of the coronal portion of the root canal. Then slight to moderate bone loss, but adequate supporting tissues. All these things are the radiographic features which indicate that you need to go for a pulpectomy procedure. Now coming to the general contraindications. General contraindications, systemic diseases like congenital ischemic heart disease, then long-term child in steroid therapy, they are the general contraindications of doing a pulpectomy procedure. Coming to the clinical contraindications, furcation involvement due to the caries or a mechanical instrumentation or an internal resorption is there. Then severe mobility due to infection or pathological root resorption is there. Then physiological root resorption is there. Then non-restorable tooth. Okay, so these are all the clinical contraindications of pulpectomy. Now next is the radiographic contraindications. So when you see the indications, how I have put across is, one is a general contraindication, next first is the clinical, then radiographic. So try to put the indications and contraindications in this way. Now radiographic contraindication is severe internal resorption. Imagine that entire one root is internal resorption is there, you cannot do anything to extract it, that's all. Then pathological or physiological root resorption involving more than 1/3 of the roots. Then excessive pathological bone loss. So these are all the indications and contraindications of pulpectomy. Endodontic instruments. You guys will be well versed in endodontic instruments. I'm just going through that. First is exploring instruments to locate the root canal, so that and to assist in obtaining the patency of the root canal. That can be small broaches and endodontic explorers. Debridement instruments is to extirpate the pulp and to remove the debris. That is, a barred broach can be used. Next is the shaping instruments. where you can, which helps to shape the root canal both laterally and periapically. Then obturating instruments to pack the root canal with the materials, that is example the plugger and the lentillo spirals. Then you will be well versed with the broad broaches, what is the configuration and all those things. So broad broach comes under the extirpating instruments, where you can remove the tissue, you can remove the entire pulpal tissue or a foreign material from the root canal. Then the etch-home file or etch files, which is made up of a round stainless steel machine to produce the spiral flutes, high efficiency in cutting, but fragile and fractures easily because of the configuration. Then the K-flux files, which is made of a rhomboid plank, which you guys are all studying this in your endodontics. Okay, on the rhomboidal plank, it's been twisted to form a K-file. Then it has an increasing cutting efficiency and flexibility. And nickel titanium rotary files, root canal files, all those things have been, there are in pediatric endodontics, day by day the new files are coming into the market. Coming to the single visit pulpectomy, how the procedure goes. Okay, so imagine that you have done a pulpotomy, hemorrhage is not controlled, you are going ahead. Means simple thing is extension of pulpotomy procedure, hemorrhage from the amputated radicular pulp is uncontrolled, then not gone on a tooth with an abscess or a fistula. So in these two cases, okay, so these two are the indications of a single visit pulpectomy. So first thing is you are anesthetizing the tooth, you are putting a rubber dam isolation, then the access cavity is prepared. So you guys will be very well versed how the access cavity will be preparation, or objectives of the access cavity is obtaining the straight line access, then the conservation of the tooth structure, then unroofing the chamber, followed by the exposure and removal of the pulpal horns. So these are all the three main objectives of access cavity preparation. So upper and lower molars, this is how the access cavity should be prepared. Then what is the need to obtain a straight access? What is the need? First thing, the main thing is to ease of introduction of the instruments. You should be able to put the instruments and remove the instruments without any hassle into the canal. Then improves the obturation, because if you're getting a good visibility, you can be able to obturate it in a very good way. You can isolate it properly. You can clean the canal properly. Okay. Then decrease the procedural errors like ledges, perforations, and all those things. You can reduce, because you are seeing the access. Your visibility of the access is there. Then all accessible coronal and radicular pulpal tissues should be removed with broaches, so that the entire pulpal tissues come. You can remove it from the pulpal canal. Then the canal should be irrigated. So ideal irrigants that you use is sodium hypochlorite, hydrogen peroxide, normal saline, steam of hot water, and solution of chloramines. So ideally we use normal saline. So copious irrigation is required, so that the entire, whatever the debris is present, that will be flushed out from the canal. Then the working length has to be determined. The working length, you know what is the definition of the working length is. Okay, working length is the length between the apical end of the preparation to the coronal point from where the measurement is made. So always expressed in mm. It's always expressed in the millimeters. Okay. So the coronal reference points for the anterior teeth is the incisal edge, and the posterior teeth is the cuspal tips. So you can say it's a mesial cuspal tip or a distal cuspal tip. All those, that is the reference point you take. Then the methods of determining the working length, it can be either by tactile method, radiographic method, and by using a apex locator. So you have now determined the working length. So next is the extirpation of the pulp and irrigation. So ideally the canal is filed with an aim to enlarge them to permit the condensation of the root canal filling material. So ideally what you do is you will be using an edge file to extirpate the tissue, or you can use a broad broaches also to extirpate the tissue, so that the entire canal is clean. So after the extirpation of the tissue, you need to nicely irrigate it with a irrigating solution. Ideally we use normal saline as an irrigant. Then the recent thing what has come is the instrumentation of root canals. You can use either rotary instruments that come up nowadays, which will improvise in your preparation. You can use it in a very, and the time taken for the removal of the pulpal tissue is also very minimal. Okay. Now, next is now you have extirpated the tissue. Now you have done the BMP is done. BMP is done. Either it can be done with an H file. Okay. Now your preparation is done. So somewhat you will get a picture like this. So next thing is to dry the canals with a paper point and obturate with a suitable material. So next is after the filling, after obturating with the material. Okay, the canal is filled with zinc oxide resinol, which is in hard consistency. Then after that, that has been removed, and GIC restoration or coronal restoration is given. On top of that, a stainless steel crown will be placed. So this is the procedure of pulpectomy in a primary tooth. Now, is there any specification of obturating materials in primary tooth? Last time, I think one question was been asked: obturating materials for primary tooth. Okay, so it's not as same as obturating material that you guys use in the endodontics. So the main ideal requirements of the filling materials of the primary tooth is as follows: that is, it should be resorbable. Main thing is, and a succedaneous tooth is coming. Okay, succedaneous tooth is erupting, so it should resorb by itself. Next is it should be antiseptic, because any infections and all, it should be able to subside. Then it should be non-inflammatory and non-irritant to the underlying permanent tooth germ and as well as the periapical tissues. It's easily inserted. Okay, it can be easily removed. Should not be soluble in water. Should not discolor the tooth. Should be radiopaque. So these are all the ideal characteristics of a filling materials of primary tooth. Now, commonly used obturating materials in primary tooth are: one is a zinc oxide resinol paste. That zinc oxide resinol is zinc oxide without the accelerator is used. Okay, underfilling is clinically acceptable in primary dentition, but overfilling, if you do an overfilling with the zinc oxide resinol, what happens is the eugenol is an irritant. So sometimes the mild foreign body reaction can occur. Sometimes the child can tell as pain or something like that. Okay, then a difference between the rate of resorption than the tooth means there is a difference is there, because the rate of resorption of the root tooth is much higher than that of the resorption of the zinc oxide eugenol. Then next is the Vitapex. Vitapex is the combination of calcium hydroxide, iodoform, and silicon. Then next material that we use is endofloss, that is eugenol based. So zinc oxide eugenol, calcium hydroxide, iodoform, and barium sulfate are the composition of endofloss. Then the major advantages of both Vitapex and endofloss is the resorption rates are almost similar to that of the tooth. One thing. Second thing is Metapex, again, since you can see a syringe, it's available in the syringe. So application to the canal and condensing the material into the canal is easier. It's not time consuming. Whereas in zinc oxide, you have to carry it in a file and you have to place it inside the root canal. So that problem is not there in Vitapex. Now, either iodoform paste as the KRI paste, Maestro paste, Walk-Back-Off paste. So these are all once it was used. Now it's not used as an obturating material for primary tooth. But once you get a question as what are the materials you use as an obturating material, you can mention it. So most commonly used is zinc oxide resinol, endofloss, Vitapex, and Metapex are the most commonly obturating materials you use in the primary tooth. Now, what are the advantages of iodoform paste? So again, it can be easily forced into the pulp canal and axillary canals. If any paste accidentally forced beyond the apex, it is easily resorbable. It's not a apical irritant. Then resorbs simultaneously with the primary root. So till now we were talking about the single visit pulpectomy. So when it comes to the multiple visit pulpectomy, the main indications of multiple visit pulpectomy is if it's a non-vital tooth or an infection or an abscess or a chronic sinus is present, so you have to go for a second sitting pulpectomy. So in first appointment, till the extirpation is done, okay, then you need to place a intracanal medicament, place it, then recall after second appointment. After a week, you can recall. Again, you do a cleaning and shaping. Then see whether the what is the status of infection is. Then in the third appointment, you can obturate the tooth. So the procedure is the same. Only thing is, instead of doing all the things together, your first appointment you are doing till the access opening and the extirpation of the radicular pulp tissue. Second appointment you are doing a cleaning and shaping, and third appointment you are going to do a obturation. Now, recent advances is the something called as laser pulpectomy is there. Okay, so you can use the laser to remove the pulpal tissue from the canal. Okay, and you can obturate it with the material, either Metapex or zinc oxide, So with the laser light, what is the advantage of laser light is we can get a blood-free site to work. Second thing is, because of the laser, the entire tissue get necrotized and it can be easily removed from the pulpal canal. So almost 90% of the tissue can be removed from the tissue. I mean, tissue can be removed from the pulp chamber. Then next comes the obturation techniques and the quality of obturation in primary tooth. So the primary objective is the integrity and health of the teeth and their supporting structures. If it is a non-vital tooth, clinically it should be functional. So that is the major primary objective that I have already discussed, why you are going to do a pulpectomy. So the main aim of obturation should be prevent recontamination. There should not be any recontamination. So uh, to get that thing, you should have a proper coronal seal. Coronal seal is nothing but your access filling. You should have a proper coronal seal. So the canal system from either apical or coronal leakage should not be there to prevent the recontamination. And to isolate and neutralize any remaining tissue or bacteria, and to maintain the teeth functionally and clinically in the mouth. So that is the main aim of obturation. So the ideal filling technique is it should assure the complete filling of the root canals without overfilling or with minimal number of voids. Means this is how after the obturation it should look. The entire canal has been filled. So the various techniques we use for obturation is lentillo spiral technique, the pressure syringe technique, endodontic pressure syringe, mechanical syringe, tuberculin syringe, Jeffy's tube, okay, Navy's tip. These are all the different types of techniques we use in obturating the primary tooth. Sometimes you might get a question, what are the different techniques you use? So you can just name it and say, okay. So endodontic pressure syringes can be used, okay. Consists of a syringe barrel, then threading plunger and wrench and threaded needle is there. So you can place till your working length and press it so that the entire material will flow. It's nothing but how a Metapex is. I have shown a Vitapex picture. It comes in a syringe. So it's something of a different type. And the mechanical syringe is nothing but the normal syringe, the gauge 22 gauge pressure syringe you use. You can fill the material into the pressure syringe and you can push it into the root canals. Tuberculin syringe is not your insulin syringe, but the same thing. You are putting the material into the barrel of the syringe and then you are pushing the material into the root canal. So these are all helps, and these are all the things that helps in the faster application of the obturating materials into the canal. So this is the Navy tip. So you can see here the tip itself is like it's literally going to the tip, the base of the root canal. Then next is the moist cotton technique. So here what we do is mix of syntoxygenol and is taken and it has been filed entire or been coated entire surface of the root canal. Then or root canal or with the thin paper points also you can take it and coat the entire root canal with the zinc oxygenol. Then shape the thick mix of the zinc oxygenol in a cone. You can place a thick mix over here. Then nicely condense it with a moist cotton pellet. Nicely press it so that with the pressure the entire eugenol will start, zinc oxygenol will start flowing into the root canal. Then you can use lentillo spirals also. That's again little more safer than using the hand files. Yeah, there are two techniques of lentillo spirals are there. You can use a hand lentillo spiral and a slow speed, that is rotary lentillo spiral. So this is called as a lentillo spiral. Okay, it's kind of a thin spring type it will be, and it is available in different sizes like red, blue, green, and black. Okay, so red is for the 25, blue is for 30, and it goes. And it's available in 17, 21, and 25 mm. So yeah, this is a rotary lentillo spiral where you can load the butanol into the lentillo spiral, slowly place it into the canal, and slowly switch it on so that will start coating onto the walls of the root canal. So again, coming to the assessment of the obturation can be assessed by radio opacity, voids, and canal obturation. Where the radio opacity, it is radio opaque, and I have already shown that this is a obturation. Voids is this one. This is a void, which the voids usually comes if you are not properly cleaning or properly drying the canal. Then the canal obturation. Canal obturation, if you can see, is it's partially obturated. This is also not fully obturated. It's partially obturated. So these are all the things which you need to take into consideration when you're assessing an obturation of primary tooth. Now, canal obturations can be of three types. We'll say it's as underfilling, optimal filling, and overfilling. Underfilling means this is what is called as an underfilling. Means more than 2 mm short of the apex is called as underfilled. Optimal filled is one or more canals ending at the radiographic apex, or up to 2 mm short of the apex. This is called as an optimal filling. And overfilling is any canal showing material outside the root. You can see here the canals, the materials have literally gone outside the root. Then the factors that affects the quality of the obturation is the radiographic technique, the way you project, okay, or how you development, the method you use, the materials you use, operators efficiency, especially the patience you show, slowly you clean the canals, all those things, and the patient cooperation, the age, the isolation, the behavior of the child, all those things that will cause, or it will all are the factors that affect the quality of obturation. So you can see here, this is unfilled, this is unfilled, this is underfilled, this is overfilled, this is optimal, okay, this is also optimal, this is underfilled here, this is also underfilled. So these are the different. That's why I'm just showing the different types of radiographs, so that you will have a idea how a tooth looks after obturation. So this is what is called as a level of obturation. So at least till the tooth bud, when you take the tooth bud, it should be 1 mm above the tooth bud. The obturation should end. Okay, minimum. That's what Godoy says. So these are all the success rates of each materials at an undergraduate level that is not required. Okay, so this ends your pulpectomy for primary tooth.